Our presentation is on hospital acute inpatient service.
First, let's begin with definitions. First, we have CMS. It's a federal agency that regulates and organizes Medicare and partners with states to administer Medicaid. Next, IPPS, which is a system of payment for operating costs for hospitals, and this is for inpatient stay. Next, we have MSDRG, which is a classifying system for patient stay just to categorize their treatment and care. To go along with that, we have CC, comorbidity and complication, which goes with MSDRG, which is classifying the severity of patient illness. Lastly, we have the 72-hour rule, which basically states any medical services within 72 hours must be bundled together on one bill.
These numbers represent some important figures within the hospital acute inpatient services. This is an overview flowchart showing the certain adjustments that go into getting the final payment that a hospital receives, and our next few slides will go over the individual adjustments.
So Medicare will set base payment rates for operating and capital discharge base rates. Operating payments are tied to labor and supply costs, and capital payments are tied to depreciation and interest. These are then further adjusted. They are adjusted for geographic areas by an area wage index, which is intended to measure differences in hospital wage rates among labor markets and compares the hourly wage average for hospital workers in each metropolitan area or rural area. And then this is further revised each year based on data from the IPPS hospitals. Furthermore, it's adjusted by the case mix, so it looks at the patient's condition and their expected costliness based on their DRG.
In medical education, teaching hospitals receive add-on payments to reflect the additional indirect costs of patient care associated with resident training. The size of this indirect medical education, also known as an IME, adjustment depends on the hospital's teaching intensity, which ultimately is measured by a hospital's allowed number of residents per inpatient bed. Graduate medical education, also known as GME, payments are based on hospital-specific costs per resident in a base year, the number of allowed residents, and Medicare's share of new technology. Hospitals with cases treated using certain cost-increasing technologies will receive add-on payments for new technologies. This evaluation process is by CMS for add-on payments based on a criteria of newness, substantial clinical improvement, and the costliness of the technology beyond the level of the current MSDRG payment. Hospitals that treat a disproportionate share, also known as DSH, of certain low-income patients receive additional operating and capital payments to offset the financial effects of these specific patients. A hospital's low-income patient share is defined as the sum of the proportion of its Medicare inpatient days provided to patients eligible for supplemental security income benefits, as well as the proportion of its total acute inpatient days furnished to Medicaid patients. It is important to note that any hospital with a low-income share exceeding 15% is eligible to receive operating DSH payments based on a complex formula. And a provision in the Patient Protection and Affordable Care Act allows for each hospital to receive uncompensated care payments equal to its share of a fixed pool of dollars defined as 75% of estimated aggregated operating DSH payments under the prior law DSH formula, which is then multiplied by the national uninsurance rate as a percentage of the uninsured rate in 2013. And this is defined as the uncompensated care pool.
Next, we have other adjustments. So first, transfer policy, which states Medicare reduces the MSRDG payment for patients whenever their length of stay is shorter than the average length of stay, and they are either transferred or discharged. Next, outlier policy. This policy states that Medicare will make extra payments for any cases that produces a loss for a hospital.
Finally, the last adjustments considered for this payment model try to ensure quality. These are penalties, incentives, and bad debt payouts. Under penalties, we have excess readmission and hospital-acquired conditions. These penalize hospitals for having a readmission rate above the national average and also for having a high amount of preventable injuries, falls, or infections. They receive a pay cut accordingly. To incentivize quality, CMS also allocates a 2% base rate of the DRG payments into a pool for those high-performing hospitals. And bad debt payouts are for those hospitals that have tried to collect the debt that they are owed by Medicare beneficiaries but have failed to do so. Medicare wants to make sure that these hospitals continue to accept these patients, so they will pay 65% of their debt back to these hospitals.